Today we are going to see about burns dressings, burns deformity, debridement and burns management. Let's have a look on that. The management of superficial burns, if it is very superficial burn with no epidermal loss, no dressings will be required. These burns are very painful and the topical analgesic cream may be useful. So topical silver creams we can use for that. This can be followed by use of moisturizing cream when pain has ceased. This should be chosen to protect the wound and encourage the re-epithelialization. Like hydrocolloids and retentive dressings we can use for superficial burns. If the infection is present, there is a high risk of potential infection, so antibacterial dressings are needed for that. Now we are going to see about partial thickness burn. In partial thickness burn, it is treated by hydrocolloid film, alginates, foam and antimicrobial powder which contains silver. In the management of full thickness burn, we use antimicrobial dressings like silver sulfadiazine or silver nitrate, which is commonly used. So first of all, we are going to see about the burns dressings. So hydrocolloid dressings. So hydrocolloid dressings, it look like this. The description is like it is adhesive dressing. They are impermeable to the oxygen, water vapor and have absorptive property. It won't attach to the wound, it attaches to the intact skin and surrounding area. For an example, if you have burn in your arm or hand, so this will attach to peri-wound area. It won't attach directly to your wound. What is indication for hydrocolloid wound? Let's see. It is used for full thickness and partial thickness burns wound. We can use with granular or necrotic wounds. What is contraindication for the hydrocolloid dressings? Infected wound is always contraindication for hydrocolloid dressings. What are the pros or advantages and cons or disadvantages of hydrocolloid wound? Let's see. The advantage is it provides moist environment for wound healing. It allows moderate absorption of the exudate, provide autolytic debridement. It don't require secondary dressings. The main disadvantage is trauma to the surrounding intact skin while removing. For an example, if you are removing this, if you are peeling off from your hand, so surrounding intact skin, it is damaged. It may get tear if you are pulling it out. Let's see this hydrogel dressings. It is water-based and non-adherent. What is the indication of hydrogel dressing? It used when wound needs moisture, means moisture retentive environment is needed, so at that time we use hydrogel. It is used in superficial and partial thickness wound like blister, pressure ulcer, etc. It is also used for minimal drainage wounds. What are the contraindications? It can't be used with excessive drainage wound. What are the advantages? It provides autolytic debridement. It decreases pain and pressure. It is moisture retentive, so enable the wound healing. What is main disadvantage? Secondary dressing is required after some time. Let's see the transparent film dressing description. It is very clear, adherent and non-absorptive. It is permeable to the oxygen, water vapor but not the water. Let's see the indication. Used for partial thickness wound with minimal exudate. Contraindicated for infected and macerated wound. As we have seen, the macerated wound, it become moisten and softening of the skin with white color. If we are applying this, it will become very horrible for that patient because it will peel all the white color skin and sometimes it will tear the peri-wound area also. Same thing for infected wound, we cannot apply this. What are the pros and advantages? It gives moisture environment, provide autolytic debridement. Easily we can visualize because this is transparent. The cons or disadvantage: excessive accumulation of exudate results in wound maceration. If there is collection of the exudate in transparent film, it won't come out and wound will become macerated and softening of skin will occur. It is more adhesive to traumatic areas. Let's see the foam dressing. It's like a sponge polymer. Some have absorptive capacity, somewhat absorptive. It promotes moist wound healing, hydrophilic inside and hydrophobic at outside. Hydrophilic means inside it is having moisture retentive and outside hydrophobic. Phobia means we have fear, so it won't allow water to stay outside. Indicated for partial and full thickness wound. There are no specific contraindication. Let's see the pros or advantage of foam dressing. It provides autolytic debridement. It gives moisture environment as it is hydrophilic inside. It's adhesive and non-adhesive in foams. It provides moderate absorption. Let's see disadvantage of foam dressing. It may cause excessive friction and damage to peri-wound area due to lack of transparency. Now we are going to see about the gauze dressing. It is made up from absorptive cotton or fabric or synthesis. It's permeable to the water and oxygen. What are the indications for gauze? Let's see. Infected and non-infected wound, wet to wet dressing or wet to dry or wet to moist debridements. We are using the gauze dressing. There is no specific contraindication. Let's have a look on advantages of gauze dressing. So it is cost effectiveness, it is not costly. It can be used with other topical agents like sulfur we use for skin infections, or we use sulfur for some kind of the treatment. So for that we can apply the gauze on that. Let us see about the disadvantage of gauze dressing. So it is adhere to the wound. It requires frequent changing due to high permeability. It is permeable to the water, so we need to change frequently, otherwise it will stick to your wound band and it may create the infection. Lastly, we are going to see about the alginate dressings. This is alginate dressing. It is absorptive dressing available in the soft sterile pad or ropes. It absorbs excessive exudate and turn into the gel form that keep wound bed moisture and that promote the healing. Let's see the indication of alginate dressing. It is always used for infected wounds, partial thickness and full thickness drainage wound. It is also used for venous insufficiency ulcers. What are the contraindications for alginate dressings? It can't be used on the tendon, joint capsule or bone. Let's see advantages or pros of alginate dressings. It is having highly absorptive capacity, non-adherent to the wound, protect from microbial contamination, and lastly, disadvantages. It requires frequent dressing change, needs secondary dressing. Let's see the mnemonics for dressings. For minimum to moderate exudate, we should use occlusive to non-occlusive dressings. So how would you remember this? Just remember, Happy Harris from France is always great. Happy Harris is a bottle shop in US. So Happy Harris from France is always great. Happy means hydrocolloid. So first of all, in order to use the minimum to moderate exudate, dressings, we use hydrocolloid dressings. Harris means hydrogel. Then we can use, if we don't have these two, then we can use the foam dressings. Friends means transparent film dressing. Is means impregnated gas. And always means alginate. And great means Gauze. So Happy Harris from Friends is always great. Just remember that for minimum to moderate exudate. So if patient is having infected wound, how would you remember this? Just remember high alarm is good. This is high alarm in very loud noise I kept, and that is good because it indicates infection. Infection smells. So from this kid phase we can remember that. Just hydrogel. Alarm means alginate. Good means gas. High alarm is good. So remember, infected wound, high alarm. We need to go for hydrogel. If it is not available, go for alginate. If alginate is not available, go for gas dressing. Let's see for non-infected wound. Just remember, American have fun games. So I kept American flag for alginate. American alginate. Have means hydrocolloid. Fun games, film dressing. Games means gas dressing. So kids are playing game. Just remember, American have fun games. For high exudate, if you are coming across with the patient like that having high exudate, so what kind of dressing would you use? Absorptive to non-absorptive. So just remember, adding fun helps happy future. Adding fun helps happy future. So if we are adding something in our soup, that keeps us fun and it is very good for our future, happy future. So I'm adding salt in soup, like I adding alginate. Fun means foam dressing. Helps means hydrocolloid. To happy means hydrogel. Future means transparent film dressing. Let's see the types of graft. First is autograft. We can use the patient own skin graft for burns patient or any other patient. Then allograft or homograft. Skin is taken from cadaver skin is known as allograft. Xenograft or heterograft means skin from another species. Usually we use the pig skin, that is called xenograph. Let's see topical agents used for burns or wound. So silver sulfur diazine, it is topical antibacterial agent mostly used for Pseudomonas infection. It painless or directly applied on the wound. Let's see about the bacteriocin or polysporin. So it's bland ointment used for gram-positive organism. Silver nitrate, it has painless application but painful on removal. It is broad spectrum and non-allergic. Let's have a look on sulfamylon or methionine acetate. This is topical antibacterial agent. Diffuse easily through the eschar. So if patient is having eschar, just remember we either use methionine acetate or sulfamylon. Effective for gram-positive or gram-negative bacteria. Painful on application, may cause respiratory impairment. So be careful for that. Gentamicin is a broad spectrum ototoxic and nephrotoxic. So it is broad spectrum, but just have a look for nephrotoxicity if you are using for gentamicin. Then last one is nitrofurazone. It is broad spectrum bactericidal, but it may cause overgrowth on fungus. Means it may cause overgrowth of fungus on the wound bed. So be careful for that. Let's have a look on common deformities after the burns. So first we are going to see about the location of deformity, type of deformity, position, and which kind of splint or approach used for correction of these deformities. Let's see. So if the patient is having anterior neck burn, so they have common neck flexion deformity. So in order to prevent that, we will keep their neck in hyperextension, and the splint is used like soft collar or Philadelphia collar is used for that patient. Keep the neck in extension or keep that in double mattress. Let's have a look for shoulder, anterior chest, and axilla area. If they are having deformities, it will be in adduction and internal rotation of the shoulder. So we have to keep it in opposite position: abduction, flexion, and external rotation. So we use airplane splint. This is abduction, flexion, and external rotation we use for that patient. We can use shoulder abduction brace or airplane splint on axilla. Let's have a look for elbow deformities. For elbow, patient is having flexion and pronation deformity, so we will keep their hand in extension and supination. So for that we use the gutter splint or confronting splint or air splint. If patient is having hand and wrist deformity, so they have deformity like claw hand, intrinsic minus position. So there will be extension or hyperextension of metacarpophalangeal joint, flexion of interphalangeal joint, adduction, and flexion of thumb, and flexion of wrist. So for these patients, we are keeping their hand in opposite position, like wrist is in extension, metacarpophalangeal joint will be in flexion, proximal and distal interphalangeal joint will be in extension, and thumb is in abducted position, so intrinsic plus position. For this we can use wrist splint or thumb spica splint we can use for this patient. Dorsal extension splint we can also use for this kind of the patient. Let's have a look for hip or groin region deformity. Patient is having flexion and adduction deformity, so for that we will keep their hip in extension and abduction. So anterior hip spica splint we can use for this kind of the patient. Let's have a look for knee deformity. For them, they have knee flexion deformity, we are going to keep their knee in extension. So posterior knee splint we can use, or 3-point splint we can use for this patient. Now we are going to see about the ankle deformity. Patient is having plantar flexion deformity, so we will keep their leg in dorsiflexion. So for that, posterior foot drop splint or plastic ankle foot orthosis with cut out at the Achilles tendon we can use for that kind of the patient, and keep the leg in or ankle is in neutral position. Let's have a look for debridement. There are two types of debridement: selective debridement or non-selective debridement. So for selective debridement, removes only non-viable tissue from the wound. It is used often and performed by sharp debridement, enzymatic debridement, autolytic debridement. These all are example of selective debridement. Oppositely, non-selective debridement means it removes both viable and non-viable tissues from the wound. It's also called as mechanical debridement, commonly done by wet to dry dressing wound irrigation and hydrotherapy. So let's have a look for selective debridement. First is sharp debridement. Use scalpel, scissors, forceps to remove the eschar. Physical therapist can perform the sharp debridement. The second selective debridement is enzymatic debridement. So for enzymatic debridement, we can apply a topical enzyme on the surface of necrotic tissue. So we can use the selective debridement for infected and non-infected wound. This debridement used in the wound which don't respond to autolytic debridement. The enzymatic debridement is slow to establish the clean wound bed. The selective debridement, another method is autolytic debridement. In this, the body uses own mechanism to remove the non-viable tissue. Common method of autolytic debridement is hydrocolloid, hydrogel, alginate and transparent film dressing. The autolytic debridement that provides moist and wound environment, so that heals the wound, that permit rehydration of necrotic tissue or eschar and allow enzyme to digest non-viable tissues. Autolytic debridement is pain-free and it should not be performed on infected wounds. The autolytic debridement will take time to heal, means it is very slow to heal. Let's see burns management. What is medical management for burns? First, we need to establish the airway for prevent cyanosis, shock and hemorrhage. We need to see the depth and extent of the burn, like width of the burn, what is the length of the burn, and undermining and tunneling also we need to note. Then we need to clean the wound and prevent the fluid loss. Injury of the examination is also necessary. Patient is having chest burn, so they have cardiopulmonary complications. In wound healing, debridement are remove dead tissue, prevent infection and promote revascularization of epithelialization. So wound cleaning is also necessary. Let's see about the exercise. As we are physical therapists, so we need to know about the exercise for burns. First of all, we need to start from active range of motion on the day of admission. Do exercise for non-burned areas, like if the patient is having a hand burn, so do exercise for the leg, breathing exercise, and have another hand which is not burned, we need to do exercise for that. Start active range of motion, then passive range of motion, because active range of motion will prevent the contracture. If patient can't perform active range of motion, then go for active assisted or passive range of motion exercises. Start ambulation as soon as possible. If skin graft from lower extremity, discontinue the ambulation. Allow the skin graft to heal. Scar management and wound care is also necessary. So graft is closed and look like a vascular, flat and soft. In the 3 to 6 months of the healing, some changes will occur, like newly healed scar look like raised and firm. Use a pressure garment for hypertrophic scar. If scar is less than 6 months, it can respond well to pressure therapy. Pressure therapy also respond if the scar is greater than 1 year, but it will take lot more time and long time to heal. Deep friction massage help to loosen the scar tissue by mobilizing the cutaneous tissue from underlying tissue and acting upon break up the adhesion. So deep friction massage will break up the adhesion and mobilize the cutaneous tissue. Home exercise program like splinting and positioning is necessary to prevent the contractures. Go for massage and range of motion exercise frequently. Thanks for watching, and for future videos, don't forget to subscribe. If you have any doubts related to topics in physical therapy exams, please let me know in my comment section so I can make a series of the videos on that. Till that time, stay positive. Bye bye.